Hello everybody, I'm Dr. Kiran. I bring warm greetings from Indira Gandhi Institute of Child Health. I'll be presenting a case on anesthetizing a neonate with congenital diaphragmatic hernia with congenital heart disease on inhaled nitric oxide. So come on, let's dive into the diaphragm dilemma, minding the gaps. This will be the overview. Coming to patient profile and history, a day 9-old male child weighing 2.9 kg came with chief complaints of respiratory distress since birth. And coming to the history of presenting illness, a male child born at 37 weeks via emergency LSCS. The baby had not cried immediately after birth and had an Apgar score of 5 and 7 at 1 and 5 minutes. In view of persistent respiratory distress, was intubated with 3 uncuffed tube and shifted to Indira Gandhi Institute of Child Health for further management. In the NICU, it was noticed that the child had a scaphoid abdomen, barrel chest, decreased breath sounds on the left side, presence of bowel sounds on the left side, heart sounds were noticed on the right side, and a continuous murmur present in left parasternal area. The chest X-ray showed dilated bowel loops in the left chest, and right shift of cardia. Child was evaluated and found to have a PDA of 4.5 mm with bidirectional shunt and moderate pulmonary hypertension. Child developed sepsis with coagulopathy, which was managed in the NICU. Preoperatively, when we saw the child on day 9 of life, he was weighing 2.9 kgs, hemodynamically stable with pre and post ductal saturation of 94 and 90%. On systemic examination, left continuous murmur was heard in left parasternal area and bowel sounds were heard on left chest. Airway examination showed no mild retinognathia. Child was on SIMV PC mode with FiO2 of 50%. Uncuffed size 3 tube was fixed at 8 cm and a PISP of 14 and a PEEP of 4 and respiratory rate of 35. So echo on day 9 of life showed that the RV function had improved compared to prior assessments and that there was a dilated RA-RV with TR, moderate pulmonary hypertension and PDA of 4.5 mm with right to left shunt. On weaning, small doses of inotropes, adrenaline and noradrenaline less than 0.05 mics per kg per minute, and child was on weaning doses of inhaled nitric oxide at 10 ppm. ABG showed compensated metabolic acidosis. The blood investigations were within normal limits. So coming to congenital diaphragmatic hernia, it is a defect in the diaphragm that leads to herniation of abdominal contents into the thorax with the prevalence of 1 in 2,000 to 5,000 live births. It can be familial or associated with chromosomal anomalies. 30% are associated with the common bacterial defects and 10% associated with syndromes, most commonly being the Goldenhain-Beckwith-Wiedemann syndrome. Mortality is 40 to 60%. Coming to the etiology, there are two reasons, and one is failure of closure of pleuroperitoneal cavity and diaphragm development, and the second is that there is lung hypoplasia causing the diaphragmatic defect. So the types of hernias are left, right, or central. The posterolateral defect on the left side through foramen of Bochdelic is the most common. Coming to the pathophysiology of congenital diaphragmatic hernia, there's a diaphragmatic defect, viscera herniate into thorax, lung hypoplasia, underdeveloped and abnormal parenchymal vascular remodeling. There's hypertrophy of the arteries, decrease in pulmonary vascular bed, and exaggerated response to endothelium, causing persistent pulmonary hypertension of the newborn. There's also associated RV hypertrophy. The cardia are compressed, and there's decreased blood flow across foramen ovale and left ventricle. There's left ventricular dysfunction and left ventricular hypoplasia. Also, the pulmonary hypoplasia causes hypoxia and hypercarbia and acidosis, which causes increased PVR, causing pulmonary hypertension and persistence of fetal circulation, leading to hypoxia, hypercarbia, and acidosis. So, therefore, there's a vicious cycle of hypoplastic left ventricle, high PA pressures, plus RV dysfunction, plus recalcitrant pulmonary hypertension of the newborn. Persistent. Antenatal diagnosis is by routine ultrasound. The high resolution USG is one of the most commonly used modality. It measures lung area to head circumference area ratio, and a ratio of less than 15 means extreme CDH and is associated with worse prognosis. Coming to one of the newer modalities of treatment, the fetoscopic endoluminal tracheal occlusion. It's a minimally invasive transuterine intervention aiming to reduce lung hypoplasia and promoting normal lung development, where it deploys a balloon in fetal trachea which occludes and prevents pulmonary fluid efflux. It stretches fetal lung, accelerating the growth. It increases number of alveoli and capillary vessels and prevents remodeling of pulmonary arterioles. This balloon is then removed at 32 to 34 week of gestation, but it comes with the disadvantage of premature birth. Predictors of poor prognosis are a birth weight of less than 1.5 kg, Apgar of less than 7 at 5 minutes, total lung volume when it's less than 20 ml, lung to head circumference ratio less than 15%, major cardiac defects and LV hypoplasia, severe pulmonary hypertension, right sided CDH with liver herniation, presence of chromosomal anomalies. Coming to the anesthetic considerations of CDH, CDH is not a surgical emergency. It needs medical optimization before surgery. So the first modality in the management is the NG tube insertion, which decompresses the abdomen and relieves thoracic pressure and improves ventilation. Intubation in cases where deemed necessary is useful to prevent air from entering the stomach and bowel worsening mechanical compression of the already restricted lung. So coming to the third most important modality in the management of CDH is maintenance of oxygenation and ventilation, wherein lung protective ventilation is used, wherein FiO2 to maintain target SpO2 of greater than 85, PaCO2 less than 65 and pH of more than 7.25, PCV or pressure control ventilation or pressure support with peak inspiratory pressures of less than 25, inspiratory time of less than 0.35 seconds, PEEP of 3 to 5, and respiratory rate less than 65 per minute. HFOV is another modality, and FiO2 1 and prone ventilation are also proven to be useful. Other methods of maintaining ventilation are permissive hypercapnia and prevention of pneumothorax. Maintenance of hemodynamics is via balancing the SVR and PVR. It should be noted that the PVR should not be allowed to increase, as we already know the factors increasing PVR are hypoxia, hypercarbia, hypothermia, acidosis, polycythemia, pain, agitation. So the first in hemodynamics, we can divide them into controlling the pulmonary hypertension. The two modalities are inhaled nitric oxide and sildenafil. Inhaled nitric oxide is now the first modality and the best modality in the treatment of pulmonary hypertension of the newborn. Or sildenafil can be used via oral IV or sublingual routes, and controlling the cardiac dysfunction and organ perfusion via inotropes, and prostaglandins can be used to maintain duct patency as last resort, but they come with the disadvantage of pouring deoxygenated blood into systemic circulation. ECMO is used when saturation is less than 85%, MAP of less than 40, pulmonary artery pressures are more than the mean arterial pressure, max inotropic and ventilatory pressures, and when there is MODS. Coming to INO, endothelium-derived relaxing factor, it's a potent selective pulmonary vasodilator via increasing the CGMP. Use of inhaled nitric oxide with early surgery, and use of and infants who respond to inhaled nitric oxide have proven to have better outcomes. Effect of inhaled nitric oxide is evaluated using PaO2 FiO2 ratio and the oxygenation index, which is a product of FiO2, an oxygenation index of 20 is deemed to be good. The higher the oxygenation index, the worse is the prognosis. It is in our institute we have the phenylephrine delivery system. It's initiated at 5 to 20 ppm, increased by 5 ppm every 12th hourly to maximum of 40 ppm. Similar doses are used for tapering off. The advantages of inhaled nitric oxide are a short T-half of 2 to 6 seconds, delivered as gas, local effect and excellent pulmonary vascular bed vasodilator, rapidly inactivated on binding to hemoglobin. Monitoring is the hemodynamics, the FiO2, ABG, methemoglobin levels should be kept less than 2.5% and nitrous oxide levels less than 0.5 ppm. Concerns requires gas flow rates to be higher than minute ventilation, need for avoiding use of volatile agents as high concentrations get delivered, sudden discontinuation avoided. Side effects: bradycardia, hypotension, altered sensorium, rebound pulmonary hypertension, bleeding and surfactant dysfunction. Pre-op assessment, we need to take a look at the antenatal and the birth history, presence of other congenital anomalies, cardiovascular status currently and trends since birth, ventilatory stability and trends since birth, fluid status, sedation and muscle relaxation, IV access, and renal and cranial ultrasound. Pre-op checklist, pre-op request, blood products cross-matched and readily available, HB of more than 10, echo 24 hours prior to surgery, chest x-ray, and drug infusions of inodilators, inotropes, and sedation for transport. Intraoperative management, ensure neonate is optimized for surgery, ensure safe transport, gastric decompression, induction and intubation, modified RSI is used, avoidance of bag mask ventilation. INO is attached to the inspiratory limb of the circuit. And flow is supposed to be maintained at greater than the minute ventilation. Atracurium is given at dose of 0.5 mg per kg. Monitoring is the routine ASA standard monitoring with special attention to airway pressures, peak inspiratory pressure, mean airway pressure, and PEEP. Echo can be a useful intraop modality to monitor PPHN, wherein flattening of the IV intraventricular septum, tricuspid regurgitation, left or right or bidirectional shunting, and tricuspid regurgitation jet is used for measuring RV pressures. Maintenance can be done with volatiles. CVO is most preferred because it blunts the HPV. No nitrous oxide to be used. Isoflurane with flows at 5 liter per minute were used by us in this case, and MAC was maintained between 0.7 to 1. And TIVA, the propofol with Stewart's model can be used. Normothermia, intravascular volume, and acid-base balance must be maintained. Ventilation should be lung protective. Any acute desaturation with hemodynamic instability, we should think of pneumothorax. Hemodynamics and pulmonary hypertension, again the balance between SVR and PVR should be maintained. Milrinone and vasopressors, inotropes to be kept ready. Sildenafil, inhaled nitric oxide to be kept ready in case of hemodynamic instability due to RV failure. Peak pulmonary artery pressures and mean arterial pressures, when they equalize, it means worse outcomes. Sudden hypotension indicates either RV failure or kinking of major blood vessels or abdominal compartment syndrome. Analgesia, multimodal, wherein fentanyl and morphine can be given intravenously with paracetamol, or regional with epidural, intercostal, or intrapleural block, or a local infiltration. Postoperative, extubation only for small isolated CDH after ruling out compartment syndrome, analgo sedation, lung protective ventilatory strategies, and slow weaning. Watch out for honeymoon phenomena, wherein there is an improvement post-op, but then there can be again sudden worsening of the PPHN. Post-op chest X-ray to look for pneumothorax and ET tube position. Surgery, what was done was transabdominal diaphragmatic herniorrhaphy with diaphragmatic mesh repair in supine position with left subcostal incision. But unfortunately, postoperatively, child was unable to be weaned off ventilator and succumbed on postoperative day 18 to type 1 respiratory failure and MOGS due to sepsis. Complications after CDH repair are innumerable. The most important respiratory being pneumothorax, pleural effusion, and atelectasis. And long term, it can cause recurrent respiratory tract infections and chest wall abnormalities, and gastroesophageal reflux disease, and can have persistent lateral scoliosis. Take-home message: CDH is a neonatal medical emergency, not surgical. Preoperative medical stabilization and optimization are needed for better surgical outcomes and survival. Multidisciplinary collaboration of neonatologist, surgeon, and anesthetist needed for best outcomes. Morbidity and mortality are high in spite of advances. These are my references. Thank you.